tachycardia, fast heart rate, can come back and have a predisposition to doing so. So what you do is you wait to see if it comes back, and after about, I don't know, 15, 17 minutes it came back. So I had to do some more ablating, and then you got to restart the waiting period over again. So
in the same place?
Same spot, yep. Yeah.
Was there only one spot?
I think so. Sometimes I guess you can't completely exclude other spots, but the areas that I ablated were all in the same spot, same location based on x-ray. Now, quite frankly, I don't need to move much on x-ray to be in a different territory, but it was all in the same vicinity. Okay. So,
where was it exactly?
Yeah, so that's what I'm going to try to draw here. Anyone have medical training?
You met me before,
Oh,
actually.
okay. Was it in
Yeah,
clinic?
with
Okay.
Joanne Van Buren. I don't know. I'm a Van Buren. My mother-in-law. You took care of her.
Mm-hmm. Yep. So, in order to understand what she had, let me explain how the normal heart beats. First of all, the heart has two chambers, two in the top called the atrium, and two on the bottom called the ventricles. And the main chamber of the heart, you know, the chamber that really truly squeezes blood out to the brain and the body, is this chamber right here called the left ventricle. That's the main chamber, all right, ventricles. So this is what determines your heartbeat. And since both bottom chambers fire at the same time, your heart rate is determined by how many times the bottom chambers fire in a minute. But it's actually the top chamber that normally tells the bottom chamber what and when to do it. So electrically, our heartbeat originates up here. It's a place called the sinus node, or SA node. This is our own little pacemaker that we're all born with. It's a spot in the top right back part of the heart that fires automatically and speeds up when we do something, slows down when you're resting. Every time it fires, it sends out a signal that makes the top chambers contract. That impulse has to get down into the bottom chamber, because remember, the bottom chamber is really where the blood gets squeezed out of the heart. And the only spot normally, and that's a really important point in you, you had one of those extra connections. So the only normal electrical connection between the top and the bottom chamber is this spot called the AV node. All right? Normally when that impulse gets through there, it flies down here and activates the bottom chamber very fast and very efficiently. So she had an extra connection, an extra electrical connection between the top and bottom chamber. On this picture, it's going to look super close to this AV, probably like that far away. All right, but this is one of those spots where we do worry a little bit more about a pacemaker. So that's the number one thing that's on our mind when we're doing this ablation. So anyway, you had this extra connection. And what this does is it sets up a situation as you can have an abnormal circuit. And the easiest way to conceptualize it is think of a circular wire. And when you're in a tachycardia like this, we call it a re-entrant tachycardia. It goes around the circuit. You know, in order to have a circuit, you gotta have a way to get somewhere and another way to get back. And that's what happens here. So you create a situation where the impulse can get down here like normal, but then it goes up here and then back down, around and around. And that's what's happening. Okay, so what did I do? I burnt that, we call it an accessory pathway. Extra connection, whatever you want to call it. And these are kind of notorious for being stubborn sometimes. That's why we have the waiting periods, especially for these types of things. They're notorious for coming back. I waited 17 minutes before it came back the first time. I did some ablations in the exact same area. Could I have been maybe this far over? Sure, my x-ray isn't that sensitive, but it was roughly the same area. And then I waited 40 minutes at the end and it didn't come back. So could it come back? Sure. I've heard of patients coming back longer. I had one guy that came back 60 minutes out after he was back in this area. But usually if you wait 40 minutes, it's pretty darn good. So, all right. Does that kind of make sense?
Yeah.
Got some puzzling looks? No?
Yep.
Yeah.
So just that one area.
That's the only area I ablated. That's the thing that I think was the main issue. Now, what I did see at the end is you had probably maybe a 20-30 second burst of something. I'm not going to make too much of it because I really don't know what to make of it. 20-30 seconds of a spot. It was probably a spot somewhere up here that was firing fast. And then you actually did go into AFib for just a short period of time, for like, I don't know, 10 seconds at the most, and then you came out of it. All right. What does that mean? It's impossible to know. It's not normal to be in there with wires in your heart. We're tickling things. Be one option going straight to the procedure. If you have recurrent symptoms, though, we have to ask ourselves, should we be thinking of something else like AFib? So I might do some more monitoring if it came back, just to make sure, because if it's truly all AFib coming on, then I don't know if I'd really, not that we couldn't do an ablation for that, it would be just a totally different type of ablation. That you go over the left side and do other things over there. So, you know, this is, remember I used the term low-hanging fruit about 3 or 4 times. This is the low-hanging fruit. This is the thing that when we see this, we can really have a high success rate with these types of SVTs, and sometimes these SVTs can play into other rhythm issues. So, you know, I'm pretty happy with how that's
So that accessory pathway, that spot, it was it on the wall next to the right atrium there? Was it?
It's actually on the, we call it the posterior septal region, which is the low region.
Posterior septum.
Yeah, which is with the low region of this chamber in the back of this chamber.
Okay.
All right. But it is in the, it's,
Yeah,
since
right
it's septal, it's right atrium, yeah. Septal is the tissue between these two chambers,
Yeah.
but it's in the back floor of that chamber. So, yeah.
And because she does have that, is there any risk of her developing any other, like whether it's AFib or a different, you know, type?
So
of
2 types of things can be associated with, well, I guess a number of things, but 2 things that come to my mind right away with accessory pathways, both of which go away if you ablate them. Number 1 doesn't really apply to her. So have you ever heard of Wolff-Parkinson-White syndrome? Okay. So these electrical connections, just like the AV node, can conduct down and they can conduct up. All right? When they conduct forward, they can, in a small percentage of people, cause what we call WPW syndrome. And that can be associated with a deadly heart rhythm. All right? Rare situations. In her, she didn't conduct down. She only conducted up. This
So
extra
that's a good
connection
thing.
only connected up. So
That's good.
she, even if, first of all, she didn't have WPW syndrome, but this accessory pathway does not pose any risk of dying suddenly, okay? Even before I got rid of it.
Good.
Now, the other thing that accessory pathways sometimes can be associated with, which I alluded to earlier, is AFib. People with accessory pathways can have those pathways trigger AFib. And in those patients, you get rid of the accessory pathway, and sometimes it's a good cure or treatment for AFib. I don't generally call ablation a cure for AFib, but this might be one of the exceptions. So either way, I think we got it and shouldn't have to worry about those things. But as far as her risk of developing other rhythm issues down the road because of her having this that's now gone, no, I don't think there's any concern in that regard.
So, did she probably have that like all of her life?
Yeah, this is some electrical properties of this accessory pathway did not allow, you know, at least perpetuation of this circuit. Maybe you occasionally had a beat or 2 that you didn't feel very much, but this is something we're born with. They don't grow spontaneously when you're 20.
Because they didn't exercise enough on us.
No, you really can't blame yourself for this, definitely.
And so, having done this now, is there any risk at all for her that somebody should have to have a pacemaker or not?
No, you know, if she would have needed a pacemaker, it would have been a complication from the procedure. That's something I would have already seen.
Good.
You didn't have any, you don't have any evidence of all of a sudden, 5 days down the road, all of a sudden needing a pacemaker. I didn't see any evidence that the ablations affected your AV node, your true electrical connection. You did great.
Okay. Okay.
So kind of routine here on out, they're gonna watch you for basically 3 more hours total. So you've already done a half hour of it. 2 hours, you'll be on bed rest like this. So basically until I think 12:45 bed rest. You have some sutures in each groin. They'll get those out. And then watch you for another hour. As long as you're doing okay around 1:45, 2 o'clock, they'll get you out of here. All right. And give me a call with any questions. Yeah, you're welcome. Take it easy for 10 days.
What kind of follow-up do you have to do with her?
A couple weeks, she's going to come back